Hello, welcome to your online lecture for the course Altered Physiology 1. In today's lecture, we're going to look at hematologic disorders of red blood cells, specifically looking at anemia and polycythemia. Before we look at abnormal red blood cells, we're going to first remind you of the composition of normal blood. When you go and have blood taken and there's blood in a vial, you would maybe look at that blood in the vial and see that it was all one color, all a red color, all uniform throughout. But what will happen with that blood is it's going to be separated into its different densities using a centrifuge unit, which is this machine that rapidly rotates and applies centrifugal force to its contents. And the goal is to separate fluid from the different densities that exist. And this allows us to see blood in its different components. Blood is far more complex than it is simple because it consists of not only a fluid, but also cells and cell fragments. If we look closely at this is whole blood. Everything here is whole blood, but we can separate our whole blood into its different densities, again, using a centrifuge unit, where we see that plasma makes up about 55% of whole blood, and it resides at the top. We have this buffy coat here in the middle, and the buffy coat represents your platelets and your leukocytes. And then what you see in red, that represents the erythrocytes, or the red blood cells, which make up the majority of what's called our formed elements. So we can say then that when we separate whole blood using a centrifuge unit, we're separating it into plasma and formed elements. The formed elements includes your platelets, your leukocytes, and your erythrocytes, but the platelets and the leukocytes will reside at the top, making up a buffy coat. And the red component represents the erythrocytes. And you can see that we have 10% more plasma than we do formed elements. Now, the plasma itself consists of many different things, primarily water, but there's various different important proteins that reside within the plasma, different ions and nutrients and gases. And then when we look more closely at the formed elements, specifically at the buffy coat, and this will become more relevant for the lecture on the disorders of white blood cells, you can see the various five different main types of white blood cells that exist. So this component here with the red blood cells, the erythrocytes, again making up the majority of our formed elements, is what we're going to be focusing on in today's lecture. So erythrocytes, erythro means red, cytes means cells. These red blood cells, as part of our whole blood, have many different roles, with the primary role being to bring oxygen or carry oxygen to all of the tissues within our body. And the reason it can carry oxygen is because it carries a lot of hemoglobin molecules. In fact, one red blood cell contains up to 250 million hemoglobin molecules. Now, each of these hemoglobin molecules contain 4 heme groups. So we can say that on each hemoglobin, there are 4 regions that will be able to carry oxygen. So it won't be pretty, but I'm going to sort of try to draw it out here. So let's say this entire structure here is hemoglobin. Okay, so this is one hemoglobin, and we know there are 250 million hemoglobin found on each red blood cell. So here's one hemoglobin. Each hemoglobin has 4 heme groups. So what we can say then, and I'll just change my color, is that we have one heme group, another heme group, another heme group, and another heme group on this one hemoglobin. Each of these heme groups are iron-containing groups. It is on these regions that we can carry oxygen. So one oxygen molecule combined here, another combined here, another combined here, and another combined here, totaling 4. So we can say then that each hemoglobin can carry 4 oxygen molecules. So how many oxygen molecules then can each red blood cell carry? Well, if each hemoglobin Each red blood cell, carries 250 million hemoglobin, and each hemoglobin can carry 4 oxygen molecules, as we looked at here. Then that means that there is a total of 1 billion oxygen molecules that every single red blood cell can carry. And that, of course, sounds like a lot, and it is, but our body requires so much oxygen all the time in order to survive. Now, these red blood cells, they don't have your usual organelles present within them. And the reason for that is because there's just no room for them. We need each red blood cell to be able to hold on to as many hemoglobin molecules as possible so that it can hold on to as much oxygen as possible as well. We also want to make sure that the red blood cells are very flexible, and if they had too many solid organelles within them, then they wouldn't be as flexible. And why do we need them to be flexible? Well, if you think of a red blood cell traveling throughout your body, traveling through different size blood vessels, and taking turns here, there, and everywhere, it needs to be able to bend and almost deform temporarily to be able to travel down different pathways and through smaller blood vessels in order for that red blood cell to get to where it needs to go, which is the tissue, where at the tissue it can drop off the oxygen. So let's get talking now about the disorder anemia. The term anemia refers to a reduction in the total number of red blood cells that are circulating in the blood, or it can relate to a reduction in the quality or quantity of hemoglobin. But at the end of the day, what this is saying is that anemia relates to our body not being able to carry enough oxygen, whether it's because there's not enough red blood cells to carry them, or the hemoglobin can't carry it to where it needs to go. Now, what causes anemia? Etiology means cause. Well, if somebody has acute or chronic blood loss, so this could be that you can have a example as a female who has a very heavy menstrual cycle and loses a lot of blood every month. She can become anemic because of blood loss. Or you could have somebody who has an ulcer that bleeds, and if it bleeds somewhat frequently over a long period of time, it can lead to chronic blood loss and therefore lead to anemia. In these cases, the total number of erythrocytes in the circulating blood has reduced. Acute blood loss could be that somebody who has suddenly started to hemorrhage can lose a lot of blood during that time and become anemic. Normally, the production of red blood cells should be balanced with the destruction of red blood cells, because remember that we destroy old or abnormal or damaged red blood cells and we make new ones, this constant fresh supply, but this should be equal. So if all of a sudden we have a reduction in the production of erythrocytes, but we're still destroying the same amount, we're going to end up with less red blood cells circulating within our system. Similarly, if we have an increase in the rate of erythrocyte destruction and we're not producing any more to balance that out, it can lead to anemia. Or some people can have a combination of the above variables. Now, the main physiological alteration of anemia or effect is going to be this reduced oxygen carrying capacity and therefore tissue hypoxia. So if we don't have enough red blood cells, or if we have something wrong with our hemoglobin and we can't carry enough oxygen to our body, that being that 1 billion oxygen molecules per red blood cell, and there are tons circulating throughout the body at any given time. We're talking trillions, 20 to 30 trillion red blood cells at any given time. If this number is reduced, or if the quantity or quality of hemoglobin as part of the red blood cells is affected, then it can lead to tissue hypoxia, which means cells are not getting enough oxygen for proper function. Some of the classic symptoms that can coincide with anemia include feeling fatigued, just don't have enough red blood cells to provide oxygen to structures to function properly, weakness, dyspnea, which is shortness of breath or difficult or labored breathing, and pallor, which is an unhealthy pale appearance. We can classify anemias in different ways. We can classify them according to their etiology or their cause, and we talked about these three on the previous slide. But we can also classify anemias based on the changes that occur to the red blood cells in terms of their size and their shape and their hemoglobin content. And this is a common way to classify anemias because it provides quite a bit of detail, as you'll see shortly. The first term is macrocytic. Macro means large and cytic means cell, so these are large cells. These are cells, red blood cells that are larger than normal. Whereas microcytic, micro means small, these are red blood cells that are smaller than normal. The term normocytic describes a red blood cell that is of normal size, but as you'll see, there would be something else that is problematic when we use this term with anemias. Okay, so too big, too small, normal size. The term anicytosis refers to if you look at a smear of blood under a microscope, anicytosis would be used when you're looking at the red blood cells and you see that they take on so many different sizes, various sizes. And so you could have some that are too big, some that are normal, maybe some that are too small. The term poikilocytosis is when you look at a smear of blood under a microscope and you see that the red blood cells actually take on various different shapes. So they could be that normal circular shape, or they could take on a sickle shape, which we'll see later on. We can also classify anemias based on changes that affect their hemoglobin content using descriptive terms such as normochromic and hypochromic. So chromic here, when you see this term, we're referring to the hemoglobin content. So if a cell is described as being normochromic, it means that it has the normal amount of hemoglobin present within it. If a cell is described as hypochromic, it means that it has a lower than normal amount of hemoglobin present within that red blood cell. And so what we'll see soon is that we will take these terms and combine them with these terms to describe a particular type of anemia. Here are some different types of anemia where we're going to be describing these or classifying the anemias based on their red blood cell size and their hemoglobin content. So we have macrocytic normochromic anemia, which means that the red blood cells are larger than normal, but the hemoglobin content is normal. We have cells that are microcytic, hypochromic, meaning that they're smaller than normal cells and have a less than normal amount of hemoglobin. And then there are anemias that are considered normocytic, normochromic, where they have the normal size, the normal hemoglobin, but they're still part of an anemia, and I'll explain why shortly. So let's match these up. Macrocytic normochromic anemia examples include folate deficiency anemia and pernicious anemia. We will talk about these a little bit later. Microcytic hypochromic anemias include iron deficiency anemia and sideroblastic anemia. And normocytic normochromic anemias include sickle cell anemia. So what we will do is talk about iron deficiency anemia, folate deficiency anemia, pernicious anemia, and sickle cell anemia in today's lecture. But there's also a type called hereditary hemolytic anemia, where hemolytic is the breakdown of red blood cells, and people can inherit a condition where they break red blood cells down faster than they produce them. And so the blood cells that they have are normal size and normal amount of hemoglobin, but the body has broken down red blood cells too fast, so overall they have less amount of blood in their system. Let's spend a moment talking now about the kidneys and the role that they play in erythropoiesis. Erythropoiesis is the generation or formation of red blood cells. Again, erythro is red, referring to red blood cells. Poiesis is the generation of or formation of, and the kidneys play a role in erythropoiesis. Now, why do the kidneys play a role, or how do they play a role? Well, let's look at this feedback loop here. Let's say there's some circumstance where there's a reduction in the amount of red blood cells in the body for some reason, or Maybe there's less hemoglobin synthesis, or tissues are not getting, or the kidneys even are not getting the normal amount of blood flow. Maybe the person's bleeding. Maybe we're using more oxygen than we are able to, easily replace. But in any case, in all of these events, the body does not have enough red blood cells or enough oxygen available in it, and the kidneys pick up on this. And what the kidneys will do when they detect that there is a reduction in oxygen availability for some reason within the body is they're going to release a hormone called erythropoietin. And erythropoietin is a hormone that will go to the bone marrow where blood cells are produced, stimulate the bone marrow to produce more erythrocytes. More erythrocytes would be released into the blood. This would be really a feedback mechanism to the kidneys, where the kidneys will detect, okay, now we have enough oxygen, so I don't need to produce any more erythropoietin. So this is a homeostatic mechanism that occurs very frequently on a regular basis to keep our body in balance, but when there's underlying conditions, sometimes the kidney cannot compensate enough for proper body function. And so what we'll do now is we'll look at the different types of anemia that exist. This slide is really an introduction to the different types of anemia, and then we're going to break a few important anemias down into a little bit more detail. At the top of the slide, this image is showing you erythrocyte differentiation. Remember again that red blood cells, just like other blood cells, are produced in the bone marrow and before they are put into the circulatory system. And there's that term erythropoietin, or EPO for short, which can stimulate the production of red blood cells. But in any case, we have this we have this differentiation occurring, or specialization of these cells, and what we end up with putting into the blood is this cell called a reticulocyte. And within a very short period of time, this reticulocyte that's left the bone marrow and has entered the blood supply is going to differentiate into its final form, undergoing many different processes where it will become an erythrocyte. It's lost its nucleus, as you can see, and now at this point it's going to achieve its final size and final shape and its maximum amount of hemoglobin content. And we know that red blood cells will circulate for about 120 days before they are considered old, and then certain organs in our body, such as the liver and the spleen, will phagocytose those red blood cells and break them down into their components and recycle what we need and get rid of what we don't. And then the red bone marrow will produce more to compensate for that loss. And so we should have that balance between red blood cell production and red blood cell destruction in order to avoid certain cases of anemia. There are certain anemias that occur that are related to some problem in DNA synthesis. So when the red blood cell is actually developing, there's some alteration in DNA synthesis. And this can be because of missing important vitamins that contribute to normal DNA synthesis. And so if somebody is deficient in a certain vitamin, it can affect the DNA synthesis of that red blood cell, which can lead to a change in that red blood cell size. And so we call these macrocytic or megaloblastic anemias. Macrocytic, we talked about that being a large cell. Megaloblastic is another term that you might see, just means large, mega, large. Okay, so I'll repeat that maybe in a slightly different way. If somebody is deficient in certain vitamins, and we'll talk about those in a moment, when red blood cells are forming in the red bone marrow, there's going to be many different processes that occur, including the synthesis of DNA. If you're deficient in certain vitamins, it can affect proper DNA synthesis, which can cause the red blood cell to grow too large than it's supposed to. And if it's too large, it's considered abnormal. And these larger cells are called macrocytic or megaloblastic. Now, why this is a problem from an anemia perspective is that we know that our spleen and our liver is going to break down old red blood cells, so ones that are senile at about 120 days. But in addition to phagocytosing old red blood cells, certain organs such as the liver and spleen will also phagocytose abnormal or injured red blood cells. And a large red blood cell is considered abnormal. And so our body will break down these abnormal red blood cells because they're too big, but we won't be producing enough to replace the ones that we've lost. Vitamin B12 deficiency anemia, vitamin B12 deficiency, I should say. If somebody does not have enough vitamin B12, it can lead to problems with DNA synthesis, causing larger than normal red blood cells that end up being broken down too quickly. So if somebody is deficient in vitamin B12, it can lead to what's called vitamin B12 deficiency anemia, also known as pernicious anemia. Pernicious means severe. This used to be considered a very severe anemia once upon a time. But why would somebody be deficient in B12? Well, commonly it's because they have some sort of disorder relating to intrinsic factor. We've talked about this so many times in this course in anatomy, where intrinsic factor is that substance that's produced by parietal cells within our stomach, and it acts like a bodyguard to B12, carrying it through the stomach, through the destructive nature of the stomach, into the small intestine where they will be absorbed together, and then vitamin B12 will be used to produce red blood cells, in particular contributing to DNA synthesis. So if somebody is not producing enough intrinsic factor, then they're not going to be able to properly carry the vitamin B12 that they consume. Then the other side of the coin is that somebody's just not taking in enough. So if you have a vegetarian or a vegan that's not supplementing with vitamin B12, then they don't have enough available in their body, even if they're producing enough intrinsic factor to allow for proper formation of red blood cells. Another deficiency is called folate deficiency. Folate is vitamin B9. And if somebody has folate deficiency, it can lead to, as you would guess maybe, folate deficiency anemia. And why would somebody be deficient in folate? Oftentimes it's because they're not taking in enough of it. Folate is found in healthy foods, a lot of your green foods that exist in terms of vegetables. And because diets are very poor nowadays, you're more likely to be deficient in this type of vitamin. Malnutrition as well. Those that are malnourished in certain areas of the world that don't have access to fresh leafy green vegetables, among other nutrient-dense foods, may be deficient in folate. And then alcoholism. Those that drink a lot of alcohol can affect their liver's function. And we know that people that drink a lot can have liver problems. One of the things that the liver does, though, is when you consume folate, it gets brought into your stomach and then it gets absorbed in your small intestine. And it can do this on its own. It doesn't need a carrier. It does not need a carrier like intrinsic factor. It's going to make its way to the liver, and the liver is going to start the proper metabolism of folate so that it can be used to produce red blood cells by contributing to proper DNA synthesis. So if the liver is damaged and it cannot properly process this folate, then that folate can't be used in order to properly form red blood cells. What I'd like you to make note of here is that vitamin B12 deficiency anemia and folate deficiency anemia are examples of macrocytic normochromic anemia. So the hemoglobin content is not affected, but the size of the red blood cell is, in that it's too big because the vitamins necessary for proper DNA synthesis cause this red blood cell to grow out of control, leading to early destruction or hemolysis because, again, it's considered abnormal. Moving on now to alterations in hemoglobin, we'll look at iron deficiency anemia and sickle cell anemia. Iron deficiency anemia or ferropenic anemia is the most common type of anemia. And in fact, when people talk about being anemic, this is the anemia that they're likely talking about. So somebody with iron deficiency then and they don't have enough iron in their diet, this can lead to iron deficiency anemia, also known as ferropenic anemia. And the cause of this is oftentimes due to low iron intake, which is why a lot of people will take iron supplements, but it can also be caused by chronic blood loss. So you could have somebody that has, and these are the examples I gave earlier, they have a constant bleeding ulcer maybe, or chronic bleeding ulcer, or maybe it's a female that has a very heavy and long maybe menstrual cycle every month, where they're constantly or chronically losing more blood than the body can properly replace. Now, why is this important? Well, iron deficiency, why is iron important? Why is that related to hemoglobin? Well, think back to that little diagram I drew earlier where I tried to draw an example of what one hemoglobin molecule would look like. So this is one hemoglobin molecule that has 4 parts to it. There are 4 polypeptide chains, and I'm going to then just remind you that we have those 4 heme groups as part of each hemoglobin molecule, and on each one houses oxygen. What are these heme groups made up of? Well, I told you they are iron-containing groups. So we need iron then to properly form these heme groups in order to properly hold on to oxygen. So people with iron deficiency are not able to carry around as much oxygen for the reasons just described. The final example here is hemoglobin S. So somebody that has a mutation, and we talked about this a little bit in genetic diseases, but somebody that has a genetic mutation of hemoglobin can have hemoglobin S, which is sickle cell anemia. And this is caused by genetic mutations where we have a red blood cell that should be this size all the time, or this shape all the time. And under certain circumstances, such as being in an environment where oxygen is less available, so maybe they're at higher altitudes, the cell can sickle. And a sickled cell is not going to be able to carry the appropriate amount of oxygen and certainly not be able to properly deliver it to tissues. But we'll come back to that a bit later. Now I'm going to elaborate on the different types of anemia, going into just a little bit more detail, but there is some review on these slides from what we've already discussed. We're going to look at pernicious anemia, which is B12 deficiency anemia. I already told you that it is a macrocytic normochromic anemia. So remember, going back to this slide, pernicious anemia is a macrocytic normochromic anemia. And pernicious anemia is the most common of the macrocytic normochromic anemias. The principal disorder here, as already mentioned, is absence of intrinsic factor. But why is there absence of intrinsic factor? Well, there are many different examples. I've listed a few up on the screen here. One is chronic gastritis. Remember back to our digestive disorders lecture, we talked about how if somebody has an inflamed stomach chronically, it can affect how the cells within the stomach function, and it can lead to problems with the parietal cells producing intrinsic factor and therefore not able to carry B12 into the body or into the circulation. Gastrectomy, if somebody has part of their or all of their stomach removed, then they have less or no cells available to produce the intrinsic factor. There is an autoimmune condition where the body attacks its own parietal cells, and if the parietal cells have been attacked, they can't produce intrinsic factor, and then you can be born with an intrinsic factor deficiency where those parietal cells just do not normally produce enough intrinsic factor. So that's a congenital or being born with example rather than an acquired example, as can be the others. So what happens here? Well, this is pretty straightforward. A reduction in parietal cell in terms of either structure or function is going to lead to a reduction in intrinsic factor, which means there's going to be a reduction in the intestinal absorption of vitamin B12. Overall, B12 is reduced. This is going to cause a reduction in the proper production of red blood cells, which leads to pernicious anemia. So the red blood cells, instead of maybe being this shape, because of altered DNA synthesis end up being this shape. This is considered abnormal. The body identifies it as abnormal and will break those cells down faster than our body can produce new cells, leading to pernicious anemia. Some risk factors for, if we're looking specifically at gastritis, we've talked about some of these already in our digestive disorders lecture, but people who consume a lot of alcohol can irritate their stomach, causing inflammation. Smoking, even drinking hot tea can destroy or cause inflammation of some of the cells within the stomach, and H. pylori infection, which we know is a big one. Treatment is going to be giving the person B12 because they aren't able to get it by consumption through their mouth into their stomach, so it has to be given another way. So one of the ways it's done is through parenteral therapy, which is when any medications or vitamins or really any healing substances, they can be administered through injection into the body. And so you've probably heard of B12 injections before, which bypasses the stomach, so it doesn't need that intrinsic factor to be absorbed into the body. And then high-dose oral therapy is done as well. So this might surprise you. You might be thinking, well, if you're orally absorbing it, how is that any different? Well, there is some uncertainty as to why this is, but high doses of B12 are thought to help supplement those who are B12 deficient, even if they have some existing problems within the stomach. The thing with B12 deficiency anemia or pernicious anemia is that depletion of your stores can take years. So your body actually stores B12 for years before you can run out. And that can be a bit of a problem because you could have somebody that becomes a vegetarian or becomes a vegan, and 6 months or a year afterwards they decide to get blood work done and their B12 levels are normal. That's because they're still pulling B12 from their stores. And so if they don't go to see their doctor for more blood work for another 4, 5, 6 years, they can become anemic during that time as they deplete their stores. Now we'll look at folate deficiency anemia. So just a reminder, still talking about problems with DNA synthesis causing larger than normal red blood cells. Also an example of macrocytic normochromic, just like B12 deficiency anemia was or is. The most common causes of folate deficiency anemia include alcoholism and chronic malnutrition. With alcoholism, I'd mentioned that the liver, among its many roles, it will help metabolize certain vitamins, including folate, and it will prepare it for proper use by red blood cells for the DNA synthesis. So if the liver is affected by chronic alcohol consumption, then this role cannot occur properly, and then we end up with folate that is not prepared properly for its use in the production of red blood cells. Chronic malnutrition, whether it's in developing or developed areas of the world, if folate's not consumed, then we don't have it for proper red blood cell production. So whether we have reduced folate metabolism because there's a problem with the liver, or we have inadequate intake, we're going to have this reduction in folate, which is going to affect, we've talked really about DNA synthesis, but it does actually play a role with RNA synthesis as well. Folate deficiency doesn't just affect DNA synthesis with red blood cells. It also can affect proper DNA synthesis with other cells in our body that undergo mitosis at a rapid rate, where, remember, with mitosis, your DNA synthesis is a very important component of that. And the skin, so skin cells, bone marrow cells, intestinal cells all undergo mitosis at a rapid rate and therefore need proper DNA synthesis. And if DNA synthesis is affected, as it can be with folate deficiency anemia, then it can lead to problems with repair of the body as well. But because we're talking specifically about red blood cells, we know that a reduction in folate is going to cause a reduction in proper erythropoiesis, which is going to lead to folate deficiency anemia. Treatment is daily oral doses of folate and the stoppage of alcohol consumption if the case is alcoholism. But what's different between when we talk about folate stores and B12 stores, we said that B12 stores can be depleted in years. It can take time, quite a bit of time for our stores to be depleted, but folate stores can be depleted in a matter of months. Now we'll move on to iron deficiency anemia, and this is a type of microcytic, so smaller than normal cells, hypochromic, with lower than the normal amount of hemoglobin present. And the common causes here include low iron intake and chronic blood loss, as I've already discussed with you. I talked about this already, but just to reiterate that our bone marrow is going to produce red blood cells, which will circulate within our bloodstream. Then they will age over time, but any that are aged, abnormal, or damaged, and when we talk about abnormal, it could be an abnormality in terms of its size or shape or amount of hemoglobin content, or any that have been damaged will enter the spleen and the liver, also the bone marrow, where let's go with an example of the spleen in this case, where they will be phagocytosed. So this here is a macrophage. So macrophages, remember, are like these big Pac-Man that go around and eat and phagocytose and digest anything that shouldn't be present within our body. So those red blood cells are going to be phagocytosed by the macrophage. The macrophage is going to take the hemoglobin out of the red blood cell and break it down into heme and globin, and we will reuse the globin here. This is really a protein, so we can break this down into amino acids and use it for the production of proteins later on. So this is how our body works to recycle whatever it can. Then it will take out that heme as part of the hemoglobin and break the heme down in its two main components, that being iron and bilirubin. Bilirubin is something that will be excreted with our bile in our digestive tract and end up in our feces and also end up in our urine. But the iron, which is the main component of interest here, we will then reuse this in our body to produce more hemoglobin or more heme groups as part of the hemoglobin. Our body, if it has extra, will also store it. It will be stored in different places such as the spleen and the liver for further use. But if somebody is not taking in enough iron, then there's less iron available to make red blood cells with the normal amount of hemoglobin present, and therefore are not able to properly carry oxygen through the body. And here's actually a good diagram that I wished I had on a previous image where you can see what I was trying to draw earlier. This is hemoglobin. It has these 4 polypeptide chains, and in the center of each, in blue, is a heme group, and the heme group is an iron-containing group that carries oxygen. So one hemoglobin has 4 heme groups, which means one hemoglobin can carry 4 oxygen molecules. But a great example here is chronic blood loss. If you have somebody who has a very heavy menstrual cycle, they're losing a lot of blood. What are they also losing? A lot of iron, because the blood cells leave the body, and along with it, so does the hemoglobin, so do those heme groups, which we know are the iron-containing groups. And so what we can't do then is take that hemoglobin and recycle it every time we're breaking down red blood cells, and recycle that hemoglobin so that we can reuse the iron, because we're just losing it from the body. So there's less available for recycling and reusing. So it leads to a state of iron deficiency anemia. This slide shows us some of the manifestations or clinical manifestations of iron deficiency anemia. You can have somebody with pallor, where they have very pale skin throughout, paleness of the mucous membranes. They can have paleness within the palmar creases as well. Colonychia can occur as well, where the nails take on this concave, rigid, and brittle appearance. And then glossitis, which is inflammation of the tongue, can occur in those with iron deficiency as well. And you can see all of these fissures that are present, but because there can be loss of, remember the papillae, which are all of those, really those bumps on the skin, can be lost as well. That can impact a person's ability to feel the different textures of food, but also taste food as well. We're going to talk about hemolytic anemia now and two main forms, hemolytic disease of the newborn and sickle cell anemia. And this is where the person is breaking down red blood cells far too quickly. And so what are some of the events that you will see in someone with a hemolytic anemia where they're breaking red blood cells down faster than the body can clear out the products of red blood cell breakdown? Well, some of the things you can see is elevated EPO. So if the body is breaking down these red blood cells at a much faster rate than we're producing red blood cells, then we are reducing our overall oxygen carrying capacity in our blood, and our kidneys, we know, pick up on that, and the kidneys will release erythropoietin, which will stimulate the red bone marrow to produce more red blood cells. But the problem is, if we produce these red blood cells, but then they're getting destroyed faster than they should be, then the kidney is constantly thinking that it needs to release EPO to produce more red blood cells because it doesn't get that feedback loop telling it that everything is okay. So elevated levels of this hormone erythropoietin would be evident. In addition to that, I told you already that when red blood cells are broken down, we're going to be producing hemoglobin, and hemoglobin is going to break down into heme and globin. The heme is going to be breaking down into iron, which we already talked about, and it's also going to be broken down into bilirubin. And bilirubin needs to be excreted by our body. So it's going to travel to the liver, where the liver will metabolize it and get it ready to be eliminated from the gut in our stool and from our kidneys as part of our urine. But if there's so much bilirubin that's entering the liver, because we're breaking down red blood cells so quick, we have more bilirubin present, it overwhelms the liver's ability to actually deal with this bilirubin, and it spills into the blood, and it can lead to increased levels of bilirubin then in the blood, which can deposit itself into tissues, causing jaundice, which we know is also called icterus. The two types of specific hemolytic anemias that we're going to talk about include hemolytic disease of the newborn and sickle cell anemia. In order to fully understand hemolytic disease of the newborn, it would be best for you to understand the different forms of blood types and transfusions and the RH incompatibility and that we talked about in anatomy and physiology. I also have a lecture that discusses this online if you do need a refresher, because I won't be going over it today. But what happens with this condition here is that there's incompatibility between the mom's blood and the baby's blood. And this could either be an incompatibility with ABO, so type A, type B, type AB, or type O blood, or it could be an incompatibility with RH. And in anatomy and physiology, we talked a lot about this RH incompatibility that can occur. And we talked about how this is a problem, this incompatibility, with second pregnancies when we talk about RH incompatibility. And it has to do with the production of antibodies that end up entering into the fetal circulation and attacking the baby's red blood cells. And when it attacks the baby's red blood cells, it means that it's hemolysing the baby's red blood cells and breaking them down at a faster rate than they're being produced. And so this is considered an acquired, because the baby's not initially developed this way, but it occurs over time throughout the pregnancy, and they're born with this condition of hemolytic anemia. This is considered an alloimmune disease, just like when somebody is given a transfusion of blood that they reject, or if it's incompatible. The reason we spoke a lot about RH incompatibility in anatomy and physiology is because it is the more serious of the incompatibilities. It's the one that needs to be taken a lot more seriously, and preventative measures need to be taken in comparison to the ABO incompatibility. And once again, if you would like a review on blood typing, transfusions, and RH incompatibility, there is another video lecture that can explain that to you. Let's look a little bit at the pathophysiology of hemolytic disease of the newborn. Whether we're talking about ABO incompatibility or RH incompatibility, the mother is either containing these preformed antibodies that wouldn't like the fetal blood, or they produce them upon exposure, and that's where we talked about the second pregnancy being a problem. If enough of these antibodies, which are immunoglobulin G, cross the placenta and enter the fetal blood, this can become a problem. It can then attach to sort of like a lock and key to the fetal red blood cell, creating this widespread antibody mediated, so meaning that caused by antibodies, hemolysis. So the hemolysis will occur all throughout the body, which is the breaking down of red blood cells. So this can lead to a state of hemolytic anemia for that baby, and they need to be monitored very closely at birth. It can lead to hyperbilirubinemia. Remember that byproduct of bilirubin from excessive red blood cell production is going to be produced in extensive amounts, which can lead to an increase in the amount of bilirubin in the blood, which can deposit itself into tissues if it's not able to be properly metabolized and excreted in the urine and the stool. The baby's body can respond to this situation where its red blood cells are just being broken down so quickly by sending out all of these immature red blood cells, which are not effective red blood cells, and it can lead to brain damage, miscarriage, and death in unfortunate cases. Now let's look at sickle cell anemia. It's a type of normochromic, normocytic, or normocytic normochromic anemia where the red blood cells look normal size and they have the normal amount of hemoglobin, but there is a mutation in hemoglobin, and we know that this is an inherited autosomal recessive trait, which means it has to be inherited from both the parents. Somebody can inherit it from both parents and become affected and then have sickle cell anemia, and then others can be carriers, and carriers are rarely themselves affected, but they can pass it on to their offspring. So it's important to know then if you're a carrier, because if the person that you choose to create a baby with, if they're also a carrier, then your offspring could end up with sickle cell anemia. So what exactly happens? Well, what you may or may not have known is that the red blood cells will start off as this just normal looking red blood cells, normocytic red blood cell. And they're circulating through the body, but under certain circumstances, they can all of a sudden sickle and become this very rigid, sickled shape that doesn't move very well. Deoxygenation and dehydration, but certainly deoxygenation, is the biggest cause of the red blood cells going from their normal size and shape to this sickled shape rather. And when it's sickled, it's very rigid, and so it's not going to be able to move through blood vessels properly, which can cause major problems in the affected person. But this is reversible, and what that means is that let's say the person is in a state of deoxygenation for whatever reason, or a state of dehydration. Increasing oxygen and rehydrating the person can cause reversal in that shape, but it has to be done within a reasonable amount of time after it actually happens. There are 4 possible major events that can occur in somebody with sickle cell anemia, and we're going to talk about these just very briefly, so I'd like you to write down a basic definition of all of these terms. The first one is vaso-occlusive crisis. Vaso-occlusive crisis begins when there's sickling of red blood cells in the microcirculation. So your microcirculation, we're talking about all those smaller blood vessels. So the microcirculation experiences sickling of the red blood cells within it. And you get all these sickled cells that create really a logjam effect where they all just cluster together and obstruct or occlude the blood vessel, which behaves really like a thrombus, blocking blood flow. And this can be very painful because it can happen in many different areas of the body in the affected person. And if it's not corrected, then the tissue can start to die, as we know a thrombosis can. Next is aplastic crisis. This is when there is this sudden or acute cessation or stoppage in the production of red blood cells. So all of a sudden, with aplastic crisis, the bone marrow stops producing red blood cells. And the most common cause of this is a viral infection with what's called parvovirus B19. Parvovirus B19, which is also known as Fifth's disease. It's actually a common childhood illness. So if you have a child then with sickle cell anemia and they end up contracting Fifth's disease, the effect that can occur in this person with sickle cell anemia is aplastic crisis, where their bone marrow stops producing red blood cells for a relatively short period of time, which can cause major problems because the body's still undergoing hemolysis, breaking down red blood cells, and we're not producing really any. So it can cause a severe drop in red blood cell count and, of course, hemoglobin as well. With sequestration crisis, this is where large amounts of blood can become pooled in organs such as the liver and the spleen. So you can think of with sequestration crisis that the red blood cells that are sickled can get all stuck and cause this almost congestion within the spleen and within the liver, causing those organs themselves to not function properly. And it can actually lead to a collapse of the cardiovascular system. And finally, hyperhemolytic crisis. This is just an accelerated, beyond what is normally experienced by people with sickle cell anemia, accelerated rate of red blood cell destruction. I talked a little bit about what's on this slide already, that the abnormal shape of these sickled cells can cause them to get stuck in blood vessels and clog blood vessels in all different areas of the body. But you can see that there are many other different potential effects, and I don't want you to worry about any of the details on here that aren't explicitly discussed by me. But with the spleen, an interesting complication is that the spleen can actually experience an infarct, where there's that logjam effect at the level of the spleen. The spleen's not getting the proper blood supply it needs for survival, and it needs to be removed if it's damaged enough. And the spleen is a huge immune organ, so it can lead to immunodeficiency in these affected individuals. Now, taking a step away from these specific anemias that we've been talking about and now looking at anemia more generally speaking, anemia that is mild and develops gradually is usually easier for the body to compensate for, and the person may actually not experience any signs or symptoms of anemia unless they're physically exerting themselves. But with certain anemias, as the reduction of red blood cells continues, symptoms become more pronounced, and there can be alterations in specific organs that become apparent. And so the compensation involves our hematologic, our cardiovascular, and our respiratory system. Now, looking at the top here, and our kidneys as well, which we'll look at last, but with the hematologic system, one of the issues that we will see in somebody who's anemic, remember, if they're anemic, in many cases of anemia, they have less red blood cells circulating throughout their body. This is going to reduce the overall blood consistency, making it less viscous, more almost watery, because there's less red blood cells making up such a big part of our formed elements, making up such a big part of our whole blood. And so the blood is going to be thinner and it's going to flow a lot faster. And blood that is thinner, that flows faster, is going to flow more turbulently, leading to a hyperdynamic circulatory state, just moving so quickly. And that in itself can have negative effects. Our cardiovascular system is going to identify that our body is not getting enough oxygen, and it will respond by increasing stroke volume, so the volume of blood pumped out of the heart, and heart rate, which is the amount of times your heart will beat within a period of time. And this is going to strain the heart. And over time, if the heart is constantly having to increase its stroke volume and heart rate, it can lead to cardiac dilation of the heart, where the ventricles in particular stretch and they thin out, and then they become far less effective at pumping blood out. It can also lead to heart valve insufficiency. So the heart valves, where blood moves through to move through the different chambers and different regions of the heart, they might become insufficient, where they allow for the regurgitation or the leaking of blood, really because they've been overworked. And the consistency of blood too has changed. With the respiratory system, in order to increase the amount of oxygen available to the body, there'll be an increase in the rate and depth of breathing. The kidneys, we know, play a role in the release of erythropoietin to increase red blood cell production, but the kidneys, when they identify that their maybe blood is not as it should be, maybe blood volume overall has gone down because we've lost some of these formed elements, it will encourage this. It will be stimulated to allow us to reabsorb sodium and water in order to bring up our blood volume and therefore our blood pressure. So these compensatory mechanisms can lead to lots of different effects, such as shortness of breath, a rapid and pounding heartbeat, dizziness, and fatigue. This is a flowchart that looks at some of the clinical issues with anemia, and we've talked about some of them already. But remember, in terms of causative events of anemia, there are a variety of different ones that we've already talked about. And so what we end up with is this overall reduction in oxygen carrying capacity, leading to hypoxemia, which is low oxygen in the blood. And that leads to tissue hypoxia. So the tissues and the cells that make up the tissues themselves are going to be deprived of the oxygen that they need for proper function. This can have a lot of different effects. It can cause the liver and other organs such as the heart and the kidney over time to undergo fatty changes because of not getting enough oxygen for normal function. So it affects overall metabolism within these organs. Tissue hypoxia can lead to the central nervous system not getting enough oxygen for proper function, leading to dizziness, fainting, and extreme fatigue. In terms of effects on the respiratory system, you're going to have this increased respiratory rate and depth, and when somebody is exerting themselves, they will oftentimes have shortness of breath as their body is trying to compensate for this state of tissue hypoxia. Pallor, or skin and mucous membrane changes, where they take on this unhealthy pale appearance. Weakness and fatigue. If muscles are not getting enough oxygen, it can lead to cramping of the muscles, which is called claudication. We introduced some of our compensatory mechanisms already. We talked about how an increase in heart rate will occur and capillary dilation can occur. This means that the capillaries at the level of the tissues, they will dilate, vasodilation, in order to hopefully allow more oxygen to reach that tissue where it's dilated. We talked as well about an increase in stroke volume. We mentioned that when we have a reduction in the amount of red blood cells within our blood, it can lead to thinner blood, which can lead to this hyperdynamic state, which can affect the heart valves, leading to cardiac murmurs, which are abnormal sounds that you hear when blood is leaking back through valves that it shouldn't normally be moving back through. But it should make sense too that if there's an increase in stroke volume and you're throwing more blood into the circulation, that's also going to contribute to this hyperdynamic state. There's just so much within our circulatory system, and so it can lead to cardiac failure because so much blood is being managed and pumped out. We know that the kidneys can compensate with their role in sodium and water retention. So that brings us back to, remember, the renin-angiotensin-aldosterone system, which will allow us to reabsorb more sodium and therefore water, which is going to put way too much within our circulatory system. Another important consideration is that if the heart has to work a lot harder, then it is going to need in itself more oxygen because it is a tissue. And this will lead to a further increase in the amount of erythropoietin that is released from kidneys to stimulate the bone marrow to produce more red blood cells to hopefully help tissues such as the heart with its need for oxygen. But if the heart is not getting enough oxygen, it can lead to angina, which is a type of chest pain caused by not enough oxygen reaching heart tissue. And finally, there will be this increase in the amount of what's called dysphosphoglycerate in cells. So dysphosphoglycerate is found in human red blood cells, and it has this ability to promote the release of any remaining oxygen that's bound to the hemoglobin in the red blood cell to leave the red blood cell and go into the tissue. So we can say that this DPG, or dysphosphoglycerate, enhances the ability of red blood cells to release oxygen near tissues that need it the most. And so there'll be an increase in this in primarily what are considered your vital organs, such as the brain, the heart, the kidneys, the liver, and the lungs, for example. On our final two slides, we're going to talk about polycythemia. So we spent the entire lecture talking about anemia and the different forms. And anemia is a reduction in the number of red blood cells, but we know it can also involve a reduction in the quality or quantity of hemoglobin. But polycythemia, this is different. This is an excessive number of red blood cells, and it exists in two main forms, which is relative polycythemia and absolute polycythemia. Relative polycythemia is caused by dehydration. So if you are dehydrated, that means you're going to have less plasma, because we know plasma is made of primarily water, over 90% water. So if you're dehydrated, it's going to appear like you have more red blood cells than you should. So it's this relative polycythemia. It's because there's less of the percentage of your plasma, which makes it appear that there's more red blood cells, but there's not actually really more red blood cells that are being produced. So this occurs in states of dehydration, and that's why it's called relative polycythemia. So if you fix the fluid loss problem, then it will return the person to that normal ratio of plasma to red blood cells, or plasma to formed elements. But with absolute polycythemia, we have two main types. There's primary and secondary. Primary absolute polycythemia is also known as polycythemia vera. So that's a key word there, the vera. And this condition of polycythemia vera is where there's an abnormality in the stem cells and bone marrow, meaning that the stem cells that produce red blood cells, there's something wrong with them, and they produce red blood cells in far greater quantity than is considered normal. And we'll talk about why that's a problem soon. With secondary absolute polycythemia, this is where the body produces more red blood cells, okay? The bone marrow produces more red blood cells because there's a state of chronic hypoxia. So what does that mean? If you are in a state where your body is chronically not getting enough oxygen to its tissues, we know that this is going to cause an increase in EPO. So then EPO is going to go to the bone marrow and produce more red blood cells to compensate for this. But why does it happen? Well, there's two potential reasons, and these are important for you to know. One is physiologic. There can be a physiologic cause then of the secondary absolute polycythemia, meaning that if somebody moves from where they live now, let's say a student in your class moves to high altitudes, they're going to be in a state, if they're up there for a few months, of chronic hypoxemia. The body's not getting enough oxygen. And so the body will respond to this by producing erythropoietin to stimulate the red blood cells to increase the amount of red blood cells. And this is the body's response to there not being enough available oxygen to breathe in. So the body thinks, well, maybe if I produce more red blood cells, we can carry more oxygen. But that is not a healthy state, because now you have excessive amounts of red blood cells that are present and not necessarily enough oxygen to bind to all of those red blood cells. Pathologic, though, 3 great examples include smoking, chronic obstructive pulmonary disease, and congestive heart failure. These 2 are big ones. If somebody smokes, there's carbon monoxide present in smoke. When you smoke, the carbon monoxide is breathed in, and carbon monoxide will attach to hemoglobin, taking up oxygen spot, meaning that there's less available spots for oxygen because carbon monoxide is taking their place. And so the body will respond to that state of chronic hypoxemia by producing more erythropoietin to produce more red blood cells to hopefully compensate for this problem. So we end up with really thicker blood when we talk about especially this absolute polycythemia. And with COPD, the body is not bringing in enough oxygen because of trouble with breathing, and so the response can be, again, production of erythropoietin stimulating bone marrow for more red blood cells. Congestive heart failure, when the heart fails to pump out enough oxygenated blood to the body, it can lead to the state of chronic hypoxia. And then finally, another example of secondary absolute that's less common is somebody can have a tumor that secretes erythropoietin or causes the increased secretion of erythropoietin above normal, stimulating the bone marrow to produce more red blood cells, leading to an increase in the amount of red blood cells compared to that of normal. So why is all of this a problem? This increase in the amount of red blood cells? Well, we're going to look at polycythemia vera. Remember that polycythemia vera was an abnormality in stem cells where you're producing far more red blood cells than is considered normal, and this is very dangerous. So if you have an increase in the amount of red blood cells that are produced, it's going to increase blood viscosity. It's going to make it thinner. Just like if you had a reduction in red blood cell count, it would make your blood viscosity less, making it thinner. But this makes it thicker. This is going to increase the likelihood that a thrombosis will form, so you have more blood available to form a clot, which can then lead to the possibility of occlusion of blood vessels, which can lead to organ ischemia and infarction. And it's important to know that anytime somebody has absolute polycythemia in any of these conditions, it can increase the thickness. Then it's increasing the thickness of their blood, which increases the viscosity of the blood, which can predispose them to the development of organ ischemia and infarction. Treatment for this, therapeutic phlebotomy, where they actually remove some of the blood to sort of thin it out, and aspirin to thin it out as well by reducing the amount of clots that can form. And in the case of polycythemia vera specifically, the bone marrow, which we know the stem cells are producing red blood cells out of control, they can give suppression meds to the bone marrow to suppress their activity. So that is the end of today's lecture. Thank you so much for listening.